Good afternoon. I am Irina Trofimova, Associate Professor of Pediatrics Department with the course of Children Infectious Disease. The topic of my lecture today is preterm infant. Gestational age classification. Gestational age is important information for the obstetrician to provide obstetric care. It is clinical information for the neonatologist for evaluation of the infant and to anticipate high-risk infant and complications. Gestational age and birth weight classification help to neonatologists to categorize infants, guide treatment, and assess risk for morbidity and mortality. The major classification categorizes the infant as preterm, term, or postterm. It is based on the weeks of gestation, complete weeks of gestation or days. Defining term pregnancy, subcategorization of the 6-week period from 37 to 42 weeks. Preterm, an infant born before 37 completed gestational weeks, 259 days of gestation. Postterm, gestational age more 42 weeks. Premature occurs in 8% to 10% of births. It is associated with 85% of all neonatal deaths. Preterm has been categorized into extremely preterm, very preterm, moderate, and late. Preterm, an infant born before 37 completed gestational weeks, 259 days of gestation. Late preterm, 34 to 36 weeks, on or after the first day of the 35 weeks through the end of the last day of the 7th week, 239 to 259 days. Moderately preterm, 32 to 33 weeks, on or after the first day of the 33 weeks through the last day of the 34th weeks, 225 to 238 days. Very preterm, an infant born before 32 complete gestational weeks between 154 and 224 days of gestation. Extremely preterm, an infant born before 28 complete gestational weeks between 154 and 196 days of gestation. Infants can be classified by birth age. Some of the common terminology classification used are as follows. Micro female less 800 grams. Extremely low birth weight less 1000 grams. Very low birth weight less 1500 grams. Low birth weight less 2500 grams. Normal birth weight from 2500 grams to 3999 grams. High birth weight from 4000 grams to 4500 grams. And very high birth weight greater 4500 grams. Gestational age can be determined prenatally and the fetus and postnatally in the newborn. Gestational age is determined by the best obstetric estimate, which is based on 4 parameters. First day of the last menstrual period, physical examination of the mother, prenatal ultrasound, and history of assisted reproduction. Last menstrual period. Gestational age is calculated from the first day of the mother's last menstrual period. Since the exact date of conception is almost never known, the first day of the last menstrual period is used to measure how old the baby is. Ultrasound. The baby can be measured as early as 5 to 6 weeks after the mother's last menstrual period. Measuring the baby using ultrasound is most accurate in early pregnancy. It becomes accurate late in pregnancy. The best time to estimate gestational age using ultrasound is between the 8th and the 18th weeks of pregnancy. Fetal movement testing. Perception of fetal movement by the mother termed cognizance. Date of first reported fetal activity by the mother 18 to 20 weeks for a primal gravida and 16 to 18 weeks for a multigravida. Postnatal gestational age assessment. Clinicians usually perform a postnatal gestational assessment on every infant. It is important to perform this assessment because some prenatal estimates of last menstrual period are incorrect, and in ultrasound, especially first trimester, may not have been done. Another benefit is that it can confirm the obstetrician's date and may provide additional information relevant the developmental stage. There are many methods to assess gestational age, including rapid assessment of gestational age at delivery, direct ophthalmoscopy of the lens of the eye, and various examinations, including assessment of physical and neuromuscular maturity. There are multiple methods for repeat assessment of gestational age. Most include some of the following physical characteristics: skin texture, skin color, skin opacity, edema, lanuga, skull hardness, ear form, genitalia, breast size, nipple formation, and plantar skin creases. Examinations based on the physical and neuromuscular maturity. This includes the Dubovitz method, Ballard maturational score, and New Ballard score. These approaches have used physical and neuromuscular maturity to assess gestational age. Physical criteria alone are more accurate than neurologic criteria alone, with the combination providing the best estimate of gestational age. The Ballard score criteria. The score consists of 6 neuromuscular and 6 physical criteria. The neuromuscular criteria are based on the understanding that passive tone is more useful than active tone on the indication gestational age. The examination consists of 2 parts: neuromuscular maturity and physical maturity. The 12 scores are totaled and the maturity rating is expressed in weeks of gestation, gestational age. To assess the anthropometric indicators of a newborn, use the growth chart. Appropriate for gestational age, defined as a birth weight between the 10th and 90th percentile for the infant's gestational age. Small for gestational age, defined as birth weight to standard deviations below the mean weight for gestational age or below the 10th percentile for gestational age. Small for gestational age refers to the size of the infant at birth and not fetal growth. Small for gestational age is typically associated with maternal factors, for example, chronic disease, malnutrition, multiple gestation, high altitude, or condition affecting the blood flow and oxygenation in the placenta, for example, hypertension, preeclampsia, smoking, and placental factors, infarction, previa, abruption, anatomic malformations, and fetal factors, usually symmetric, birth weight, length, and head circumference all depressed the same. And congenital infections, TORCH, abbreviator, toxoplasmosis, AVA, rubella, cytomegalovirus, herpes simplex virus, or chromosomal abnormalities and congenital malformations, for example, dysmorphic syndromes and other congenital anomalies. Fetal diabetes mellitus, familial causes, multiple gestation, constitutional. Intrauterine growth retardation is a reduction on the expected fetal growth of an infant. The failure to obtain optimal intrauterine growth is due to an uterine cell. There is no standard definition, but a fetus at less 10th percentile weight for age or with a ponderal index less than 10% is sometimes used to classify an infant as intrauterine growth retardation. Note: small for gestational age and intrauterine growth retardation are related but not synonymous. All infants born small for gestational age may not be small as a result of intrauterine growth retardation. All infants born intrauterine growth retardation may not be small for gestational age. Small for gestational age is a clinical finding and intrauterine growth retardation as an ultrasound finding. Constitutionally small infants includes 70% of infants with a birth weight below the 10th percentile. They have no increased obstetrical or neonatal risks. They are constitutionally small, anatomically normal, well proportioned, and have normal development. They grow parallel to the lower placental throughout pregnancy. Mothers are usually slim, petite women. large for gestational age, defined as birth wage 2 standard deviations above the mean wage for gestational age or above the 90th percentile for gestational age. Large for gestational age can be seen in infants of diabetic mothers, maternal or gestational, infants with Beckwith-Waddiman syndrome or other syndromes, constitutionally large infants with large parents, postmature infants, gestational age more 42 weeks, and infants with hydrops fetalis. Large for gestational age infants are also associated with increased maternal weight gain in pregnancy, male sex, congenital heart disease, especially transposition of the great arteries, islet cell dysplasias, and certain ethnicities. Large for gestational age infants are sometimes referred to as infants with macrosomia. Risk factors associated with preterm birth. Maternal factor. Acute abdomen, surgical abdomen, pyelonephritis, anomalous uterus, significant myomata, previous scan biopsy, cerebral insufficiency, diethylstilbestrol exposure, placenta, abruptio placenta, placenta previa, subchorionic hemorrhage. Membranes. Premature rupture of membranes. Tissoditis. Retaining intrauterine device. Fetal factors. Multifetal gestation, anomalous fetus, polyhydramnios, fetal demise. Idiopathic, previous preterm delivery, and lifestyle risk factors. They are physical fatigue, physiological stress, smoking, cocaine, or other drug abuse. Problems of prematurity. Neurologic problem. Premature infants are at risk for acute neurologic problems. Intraventricular hemorrhage is the most common of preterm birth. The occurrence is greatly associated with the persistent presence of the germinal matrix. Chorioamnionitis, acidosis, birth asphyxia, shock, blood pressure fluctuation, and respiratory distress associated with hypocapnia, hypercapnia, hypoxemia, or mechanical ventilation are common related problems. The germinal matrix located between the caudal nucleus and the ependyal lining of the lateral ventricle is normally not seen on cranial ultrasound. When germinal matrix hemorrhage occurs, it becomes readily identifies by ultrasound and is seen as subependymal bleeding originating between the groove of the thalamus and the head of the caudate nucleus. Bleeding may be confined to the geminal matrix, or it may rupture into either lateral ventricle and thereby become a unilateral or bilateral geminal matrix intraventricular hemorrhage. Incidence. The overall occurrence of intraventricular hemorrhage in preterm infants less 1,500 grams is about 18% to 25%. Rates vary by gestation with the greatest risk of geminal matrix intraventricular hemorrhage in preterm infants with birth weight less 750 grams. Intraventricular hemorrhage is rarely seen in term infants. Pathophysiology. The geminal matrix is a highly vascularized area. The geminal matrix vessels exhibit a variety of characteristics that underlie the fragility and the propensity for hemorrhage. The geminal matrix begin to involute after 34 weeks postconceptual age, and thus the peculiar vulnerability and predilection for geminal matrix intraventricular hemorrhage for preterm infants lessens. Fluctuations in cerebral blood flow play an important role in the pathogenesis of geminal matrix intraventricular hemorrhage because sick premature infants have pressure-passive cerebral circulation. A sudden rise or fall in systemic blood pressure can result in an increase of cerebral blood flow with subsequent rupture of the germinal matrix vessels. Decreases in cerebral blood flow can also result in ischemic injury to the germinal matrix vessels and surrounding tissues, making them prone to secondary rupture flow reperfusion. It is the site of production of neurons and glial cells of the cerebral cortex and basal ganglia. Geminal matrix destruction may result in impairment of myelination, brain growth, and subsequent cortical development. Moreover, in preterm infants, geminal matrix intraventricular hemorrhage leads to a reduction of cerebral perfusion in the first 2 weeks after the hemorrhage. The reduction was found to be most severe around day 5 and was irrespective of the intraventricular hemorrhage grade. Post-hemorrhagic hydrocephalus is more common in infants with the highest grade of hemorrhage. It is most frequently attributable to obliterative arachnoides, either with occlusion of the arachnoid villi or in the posterior fossa with obstruction of outflow of the fourth ventricle. Rarely, aqueductal stenosis is caused by an acute clot or reactive lysis. The geminal matrix intraventricular hemorrhage classification by Papal gives grades 1 to 4. Grades 1 and 2 are small hemorrhages. Grade 1 is hemorrhage only seen in the germinal matrix, 40% of all intraventricular hemorrhages. Grade 2 shows hemorrhage from the germinal matrix extending into the lateral ventricles but without ventricular dilation, 25% of all intraventricular hemorrhages. Grade 3 shows hemorrhage filling more 50% of the lateral ventricles that are consequently enlarged 20% of all intraventricular hemorrhages. Grade 4 is marked by extension of the hemorrhage into the surrounding brain, white matter, parenchyma, 15% of all intraventricular hemorrhages. Periventricular leukomalacia is a frequent accompaniment of intraventricular hemorrhage, but is not directly caused by intraventricular hemorrhage. Periventricular leukomalacia is an ischemic brain injury followed by necrosis of periventricular white matter adjacent to the lateral ventricles. It is usually a non-hemorrhagic event resulting from hypotension, apnea, and other hypoxic ischemic events known to decrease cerebral blood flow. Most periventricular leukomalacia lesions are symmetrical in distribution. Short-term outcome of germinal matrix intraventricular hemorrhage is directly related to birth weight, gestational age, and the ensuing severity of the hemorrhagic insult to the immature brain. The early mortality rates first 14 days are 12%, 24%, 32%, and 45% for grade 1, 2, 3, and 4 hemorrhage, respectively, among infants whose birth weight is less 750 grams. Post-hemorrhagic ventricular dilation is mostly observed among infants with grade 3, 75% and 77%, and grade 4, 43% and 63% hemorrhage whose birth weight is below or above 750 grams, respectively. Long-term major neurologic sequelae: spastic motor deficit, major cognitive deficits. After minor degrees of hemorrhage is slightly higher than that in infants without hemorrhage and increases to approximately 50% in infants with severe hemorrhage. A higher incidence occurs in infants with intraventricular hemorrhage completed by periventricular hemorrhagic infarction or cystic periventricular leukomalacia or both. Respiratory problem. Respiratory distress syndrome was previously called hyaline membrane disease. Incidence of respiratory distress syndrome is about 85% in 28 weeks gestation and increases to 95% at 24 weeks gestation. Surfactant deficiency is the primary cause of respiratory distress syndrome. Surfactant is produced by airway epithelial cells of type 2 pneumocytes. Surfactant synthesis begins at 22 to 24 week gestation. At this age, the surfactant is immature. The surfactant becomes mature at 34 weeks. In the absence of surfactant, the small s please collapse. Each expiration results in a progressive atelectasis. Exudative proteinaceous material and epithelial debris resulting from progressive cellular damage collect in the airway and directly decrease total lung capacity. Infants have at birth some respiratory difficulty, which becomes progressively more severe. The classic worsening of the atelectasis seen on the chest radiograph and increasing oxygen requirement for this infant have been greatly modified by exogenic surfactant therapy and effective ventilator support. Using early CPEP, continuous positive airway pressure, approximately 50% of babies born on 26 to 29 weeks gestation can be managed without intubation or surfactant. The infant with respiratory distress syndrome exhibits tachypnea, grounding, nasal flaring, and retractions of the chest wall and may have cyanosis in one ear. A characteristic chest radiographic appearance: uniform reticulogranular pattern to lung fields and air bronchogram within the first 24 hours of life. Prognosis: also, the survival of infants with respiratory distress syndrome has improved greatly. The survival without respiratory and neurologic survival is highly dependent on birth age and gestational age. Major morbidity: bronchopulmonary dysplasia, necrotizing enterocolitis, and severe intraventricular hemorrhage, and poor postnatal growth remain high for the smallest infants. Next respiratory problem, this is classic bronchopulmonary dysplasia. Classic bronchopulmonary dysplasia is a neonatal form of chronic pulmonary disorder. Bronchopulmonary dysplasia was solely defined as persistent oxygen dependency up to 28 days of life. The severity of bronchopulmonary dysplasia related to pulmonary dysfunction and neurodevelopmental impairment in early childhood is more accurately predicted by an oxygen dependence at 34 weeks postnatural age in infants less 32 weeks gestational age and 56 days of age in infants with older gestational age. The incidence of bronchopulmonary dysplasia is influenced by many risk factors, the most important of which is degree of immaturity. The incidence of bronchopulmonary dysplasia increases with decreasing birth weight and affects approximately 30 of infants with birth weight less than 1,000 grams. Pathophysiology. A primary lung injury is not always evident at birth. The secondary development of a persistent lung injury is a result of abnormal repair process of recurrent injuries occurring during a critical window of the lung development. Prognosis. The prognosis for infants with bronchopulmonary dysplasia depends on the degree of pulmonary dysfunction in the presence of other medical conditions. Most deaths occur in the first year of life as a result of cardiorespiratory failure, sepsis, respiratory infection, or as a sudden unexplained death. Apnea is a common and significant clinical problem in preterm neonates. It is manifested by an unstable respiratory rhythm, reflecting the immaturity of the respiratory control system. Apnea can also be secondary to other pathologic conditions that need to be excluded before the diagnosis of apnea prematurity is seen. In contrast, periodic breathing is a benign condition and does not merit any treatment. Cardiovascular problem. Premature infants may be subject to hypertension due to hypovolemia or cardiac dysfunction and or vasodilation due to sepsis. A patent ductus arteriosus is a common problem that may result in congestive heart failure. The ductus arteriosus is a large vessel that connects the main pulmonary trunk or proximal left pulmonary artery with the descending aorta, some 5 to 10 millimeters distal to the origin of the left subclavian artery. In the fetus, it serves to shunt blood away from the lungs and is a central closure in utero may lead to fetal demise or pulmonary hypertension. In full-term healthy newborn, functional closure of the ductus occurs rapidly after birth. Final functional closure occurs in almost half of full-term infants by 24 hours of age, in 90% by 48 hours, and in all by 96 hours after birth. Patent ductus arteriosus refers to the failure of the closure process and the continued patency of the fetal channel. Factors associated with the increased incidence of patent ductus arteriosus. Prematurity. The incidence is inversely related to gestational age. Patent ductus arteriosus is found in approximately 45% in infants. Respiratory distress syndrome and surfactant treatment. Fluid administration. An increased intravenous fluid lead in the first few days of life is associated with an increased incidence of patent ductus arteriosus. Asphyxia, congenital syndromes, Patent endometriosis is presence in 60% to 70% of infants with congenital rubella syndrome, trisomy 13, trisomy 18, Robinson-Taibi syndrome, and Penta-X syndrome are associated with an increased incidence of patent endometriosis. High altitude. Infants born at a high altitude have an increased incidence of patent endometriosis. And congenital heart disease. A patent endometriosis may occur as part of a congenital heart disease, for example, congestion, pulmonary atresia with intact septum, transposition of the great vessels, or total anomalous pulmonary venous return. So, ductus arteriosus connect pulmonary artery to aorta, shunts blood away from lungs, mediated patent by presence of prostaglandins, closure secondary to increase in arterial oxygen partial pressure, decrease in level of prostaglandins. Pathophysiology. With drop in pulmonary arterial pressure, reduction in hypoxic pulmonary vascular constrictions, blood will flow through patent ductus arteriosus. This is left to right shunt. Increased pulmonary blood flow may lead to pulmonary edema, reduced blood flow to all postductal organs and form necrotizing enterocolitis. If pulmonary artery pressure rises above aortic pressure, blood will move in the other direction. This is right to left shunt. Diagnosis. Blood systolic murmur at left sternal border and echocardiography. Treatment. Most often requires only conservative management with adequate oxygenation, fluid restriction, and possibly intermittent diuretic use. A prostaglandin synthetase inhibitor that has proved to be effective in promotion ductal closure. Surgery should be performed in a patient with hemodynamically significant patent endometriosis in whom medical treatment has failed or in him there is contraindication to the use of indomethacin. In birth, normal values for the central venous hemoglobin in infants of more 34 weeks of gestational age are 14 to 20 grams per deciliter, with an average value of 17 grams per deciliter. Reticulocyte count in the cord blood of infants ranges from 3% to 7%. Premature infants have slightly low hemoglobin and higher reticulocyte counts. In healthy term infants, hemoglobin values remain unchanged until the third week of life and then decline, reaching a mean nadir of 11 grams per deciliter at 8 to 12 weeks. This is known as the physiological anemia of infancy. In preterm infants, this decline is more profound, reaching a nadir of 7 to 9 grams per deciliter at 4 to 8 weeks. This exaggerated physiological anemia of prematurity is related to a combination of decreased red blood cellular mass at birth, increased iatrogenic losses from laboratory blood sampling, short-term red blood cellular lifespan, inadequate erythropoietin production, and iron deficiency. Hyperbilirubinemia occurs in term newborn in 30%, preterm 80%, visualization of jaundice in full-term newborn with bilirubin levels more 85 micromole per liter and in preterm infant greater 120 micromole per liter. Physiologic jaundice occurs on the second and third day. This is a result of first increased bilirubin production, physiological hemolysis of red blood cells with fetal hemoglobin, shortened red blood cellular lifespan 70 to 90 days versus 120 days in adult. And second, reduced function of the immature conjugation system. The bilirubin level does not exceed 256 micromole per liter in full-term infants and 171 micromole per liter in premature infants with physiological jaundice. Non-physiologic jaundice. Onset of jaundice before 24 hours of life, if lasting more 2 weeks in full-term infants or more 3 weeks in prematurity. Higher level recurrent treatment. Jaundice present in clinically all infants. Physical examination. The accumulation of bilirubin in body tissues produces jaundice, yellow skin, and scleral icterus. Jaundice is first seen in the face, forehead, and progresses caudally to the trunk and the extremities. Pressure on the skin after pressure on the skin often reveals jaundice. The transcutaneous bilirubinometry can be roughly estimated by examining the skin of different areas of the body for jaundice. If jaundice present on the face only, this is 5 mg per deciliter according to Cromer score. If plus upper chest, 10 mg per deciliter. If plus abdomen, 12 mg per deciliter. If plus palm and soles, usually greater 15 mg per deciliter. Check for hepatosplenomegaly in physical examination help you diagnostic pathological jaundice. Hepatosplenomegaly, this is a symptom of pathological jaundice. A complete neurologic examination should be performed because bilirubin encephalopathy can occur. such as criterion of pathological gender skin. Look for signs such as poor feeding, lethargy, hypotonia, or seizures. Connective deposition of bilirubin in the brain. Occurs if the bilirubin levels are 25 mg per deciliter or higher in term infants. Starts at 8 to 12 mg per deciliter in prematurity or low birth age because have low serum albumin. The outcome in the future: choreatitosis, spasticity, cerebral palsy, hearing loss, ataxia, and mental retardation. Hyperbilirubinemia can be managed effectively by careful monitoring of bilirubin levels and use of phototherapy with blue light with distance of 400 to 500 nanometers. Phototherapy reduces serum bilirubin levels through structural isomerization of bilirubin, which is more soluble substance that is excreted without conjugation into bile and urine. In the most severe cases, exchange transfusion may be necessary to avoid herniations. Necrotizing enterocolitis is an ischemic and inflammatory necrosis of the bowel primarily. Of the bowel primarily affecting premature neonates after the initiation of enteral feeding. Necrotizing enterocolitis develops in 4% to 10% of infants weight less 1,500 grams, with the highest incidence in the most premature infants. About 10% of necrotizing enterocolitis cases occur in term infants, many of whom have pre-existing medical conditions. Risk of mortality is 20% to 30%. Immunology problem. Because of deficiencies in both humoral and cellular immune response, premature infants are at greater risk for infections than full-term infants. Prematurity, especially if less certified vegetation, is the single most significant factor correlated with sepsis. The risk increases in proportion to the decrease in birth age and gestational age. Neonatal sepsis remains a major cause of death in very low birth age infants, mortality rate of approximately 18%. Mortality due to gram-negative infections is higher than the due to gram-positive infections. Neonatal sepsis is a risk factor for long-term neurodevelopmental impairment in premature infants. Retinopathy of prematurity is a disorder resulting from the disruption of the normal development of retinal vasculature, vasoconstriction and obliteration of the advancing capillary bed are following in succession or by neovascularization extending into the vitreous, retinal edema, retinal hemorrhages, fibrosis, and traction on, and eventual detachment of the retina. In most cases, the process is reversed before fibrosis occurs. Because it is found chiefly in premature infants, it is called retinopathy of prematurity. Risk factors: prematurity and transient hyperoxemia. Sequelae: myopia, strabismus, amblyopia, glaucoma, blindness, and lane detachment require regular follow-up. Renal problem. The low glomerular filtration rates of premature infants is the result of low renal blood flow but increases considerably after 34 weeks post-conceptional age. The preterm infant kidney is less able to concentrate urine secondary to a relatively low interstitial urea concentration and anatomically shorter loop of Haley, and a distal tubular and collection system that is less responsive to antidiuretic hormone. Nutritional problem. Breast milk is important for babies who are preterm, low birth weight, or have special needs. Its pretext provides food and aids in growth and development. Enteral feedings with human milk should be initiated as soon as clinically possible, ideally within 24 to 48 hours. Preterm infants are at risk of postnatal growth and nutritional failure if they are deprived of in utero transfer of nutrients, particularly proteins, fats, and minerals. Early enteral feedings are associated with better endocrine adaptation, enhanced immune functions, and gut maturation, decreased time to attain full fits, and earlier discharge without an increase in risk of necrotizing enterocolitis. Also, the intake of proteins, both enteral and parenteral, and a shorter time to regain their stage positively influence neurodevelopmental outcomes. Aggressive feeding and rapid weight gain predominantly as fat deposition increase the risk of subsequent metabolic syndrome. The approach to feeding will depend on the individual baby and its condition. Behavioral care can be divided into categories based on the baby's ability to suckle. If baby not able to take oral feeds, encourage the mother to express her milk to keep up her supply for when her baby can take oral feeds. If possible, freeze her expressed breast milk and use it later. If baby able to take oral feeds but is not able to suck at the breast, give expressed milk by tube and by cup if baby is able. If baby able to suck but not for full feeds, let baby suck whenever baby is willing. Frequent short feeds may tie the baby less than long feeds at long interval. Give expressed milk by cup or tube in addition to what the baby can suck. If there are contraindications to oral nutrition, parenteral nutrition should be initiated to provide adequate protein and caloric intake in improve weight gain. The chance of survival of neonates is markedly enhanced by the successful prevention of excessive heart loss. The normal axillary temperature in the neonate is 36.0 to 36.5 degrees Celsius. Equipment and techniques: closed incubators, radiate warmer, hybrid incubator, and Tangle method. Frequent procedure disrupts the children's sleep. Weight gain is often impaired. The state of regulation decreases. A premature newborn who is in the intensive care unit has a deep sleep for only 15 minutes a day. There is a depletion of vital forces and increased pain. That is why we use monitoring system and gentle special care. Recommendation for reducing light level: shade the top of a cradle, or incubator. If the child is in a stable condition, reduce the light level in the room for 12 hours daily. Use individual lighting system with light level control over each bed. Providing warmth to the newborn on the operation table greatly affects the post-operation period. Position of the newborn: change the position every 2 to 3 hours. Lie the baby comfortably, snugly using a roller or diaper. Put the diaper roller under the thighs to prevent the legs from moving away when the baby is on the stomach. Put a water or air pillow under the children's head to prevent bed sores and changes in the shape of the skull. And support the soles with rolls in order to prevent sprains of the ankle joints. In neonatology, the term golden hour refers to the initial 60 minutes of an infant's life following delivery when a critical transitory period of adaptation takes place, particularly for high-risk neonates. Optimizing thermoregulation, glycemic control, cardiorespiratory support, and nutrition during this time is critical to achieving successful long-term outcomes. Implementation of a golden hour protocol decreases mortality as well as the incidence of hypothermia, chronic lung disease, intraventricular hemorrhage, and retinopathy of prematurity. Long-term problems of prematurity. Developmental disability. Major handicaps, cerebral palsy, mental retardation, sensory impairments, hearing loss, visual impairment, minimal cerebral dysfunction, language disorders, learning disability, hyperactivity, attention deficits, behavioral disorders, retinopathy, chronic lung disease, poor growth, increased rates of postnatal illness and rehospitalization, and increased frequency of congenital anomalies. The best way to prevent these problems is to prevent premature death. Now my lecture is over. Do you have any questions?